You had mentioned that there are many pieces of this that will be very familiar to RTC staff because they do that as part of their job.
Right.
And so maybe talk a little bit about the staffings that come up and RTC staff that come into that staffing and share their information.
Right. So it's typically every 2 weeks, and sometimes it's more intense than that. Sometimes we've done it every week, as you know, where everybody who's working with that family on a professional basis, meaning the parents and the FACS worker and case managers and our therapists and oftentimes our unit managers and sometimes our youth counselors will sit down at a table and say, okay, what do we know? And what are we learning? And what's working and what's not working? And are we staying really true to what our original intent was here? Because again, it's easy to get sidetracked when so much information can get presented in a setting like ours. So it's a way to sort of learn from each other and to refocus on what we're doing and to help families feel comfortable in terms of the process that's moving forward, because it's an anxiety-producing experience for families too. They get quite well, I think that there's some variability to that, but some families get quite anxious. So we're going to be able to finish all this in 30 days. What's going to happen when they come home, and is this going to really work? And is the child going to be, fixed? And our intent is really not to fix the child. That's the sort of what we're the change, really the paradigm shift. We're not fixing the child. We're sort of learning some things, and then helping them take those things and move forward when they leave.
Great way of looking at it. And I think part of what I think would be helpful for RTC staff to know is that they play such an important role in that process. And again, because it's kind of a shift, it might be, given 30 days. But I think as we're learning as we go along that they play a much more important role. And I've certainly learned to appreciate that role over the course of doing this work, that seeing them much more critical to the treatment process.
Well, they're highly experienced staff, and they see hundreds of kids every year and work through these kinds of processes with them. So it is, I think, a developmental learning for all of us, because you're right. The model is that the outpatient therapists are meeting with them several weeks before they come in. They are in charge. They're really the therapeutic lead in these cases, and the therapists in the residential are not the leads, but they play really a pretty critical role in terms of what's happening and what am I seeing and what am I observing and what kind of input can I give into this process about what I'm seeing. And so I think we're learning to sort of continue to be a supportive to really the staff in the residential, that we're really not just a holding tank for 30 days. We're not really just providing a break for these kids so the family can sort of catch their breath a little bit and then carry on with what are difficult situations for them. We're really providing a pretty critical role.
And more often than not, I guess this is speaking perhaps more to the therapists on the unit or at the facility, is that they are often taking an active role in doing co-therapy with the in-home therapist who is coming in to the facility, and they may be doing individual outside of perhaps the family therapy component, and they oftentimes are having frequent contact with the parent about the child as well.
Right. Well, we're taking care of the child during that period of time, so it's inherent that we're not substitute parents, but we are substitute caregivers for that 30 days.
Okay. Maybe talk a little bit about what perhaps some of the benefits of this type of model might offer.
Well, the exciting part for me really is that the carryover that happens after kids leave. That is always a struggle historically when kids come into residential. The intensity of their needs are quite high. The community is not, I will say, from a larger perspective, the community has not always been as well prepared about how to address the needs of the kids when they leave residential, that group of kids. And so the exciting part of this is that that's really being created around this family before they even come in. So there's really no transition work that's happening, a transfer from our staff to the outpatient staff. It's happening even before they walk in the door. And so not only is it seamless, but we also know that those families are going to be taken care of when they leave. The work is not stopping. It's just one or the second stage of the whole process, and they've got several other stages to move through.
Right.
So then, and so that's the exciting part. Then the hope is, from a professional standpoint, we're not seeing the rotating door, where kids are coming out and then, coming back in, and going out and then leaving the home again.
Right.
We all frankly want them to be successful in the community.
Right, yeah. And because it's that same therapist that, part of the critical role at the RTC portion, the information that they share, that the therapist, the CIBS therapist who has been involved can continue that work and carry the information that been learned through the RTC portion back into the home as the child, again, readjusts to being back in the community and the work that needs to continue there.
Yes.
Right. Okay, good. What might be maybe a challenge, things that are, you mentioned some of the shift in thinking that, has to go into these types of cases.
Well, it's not uncommon to hear from staff in a residential setting, because we do get to see so much, that staff have, I think, some anxiety about, oh my gosh, what about this?
Right.
And how are we going to address this? I mean, because again, we see lots of things when a kid comes in, more than just maybe sort of the specific goals that we're trying to target. And so it is a challenge where people will go, gosh, I wish I had this child for another month, or I wish I had him for another 4 months, because they want to do good work, and they see what's there in front of them, and they know what they've been able to do in the past, and they've been comfortable with that sequence of how it works. And so it is a shift in your mind in terms of what's my particular role with this child right now. And as you know, kids present with really challenging behaviors. And so some kids, when they're getting ready to leave, we really almost universally see a pattern when kids are close to discharge, that their behavior will dip down to almost pre-admit levels, just due to the anxiety of discharge and what that means for them. And they work through that whole process again, within a couple of weeks before they leave. But we're seeing the same thing with the kids in the CIBS model, even it's just compressed. And so that's also anxiety producing for staff to see that dip and go, oh my gosh, are they ready to go home?
Yes.
And so then there's that tension about, gosh, are we doing the right thing for this child?
And I appreciate that in some ways. It is. I think you mentioned a leap of faith in some ways for workers, because within this model, I mean, children are going on visits right out of the gate. Whether first visit sometimes is often in the community or on the grounds, but usually by that first or second weekend they're having home visits, and then quickly moves to overnights within that relatively compressed time frame. And so, I think staff sometimes. The difference being that sometimes kids have to go through certain levels before they get to that point of doing home visits, but that's not necessarily the case. Can you speak a little to that?
That isn't so much of an issue for us because we don't have a level system.
Okay.
It's St. Joe's, and so we have some basic expectations in terms of, do we know, when a child comes in, that you're going to be safe when you go out into the community? Are we hopefully not going to have a repeat of what brought you in here to begin with within the first week or two? Because we experienced that. It's quite difficult. Somebody comes in from the hospital and you're not going to send them out the door again to be rehospitalized again within the first week or two. But even for us, since we don't have a level system, we're just assessing what's the safety needs and what's the overall goal that we want to do, and if passes can start to happen within a couple weeks, and then that begins to happen. So that part has really not been much of a barrier for us.
Great.
Where my head was before, I'll just talk a little bit, is that I think there's some anxiety about when kids come in and they're going to spend 30 days with us. I think on our part, in terms of how are these kids going to fit into the milieu? Are they going to be treated differently? Are they not going to be real residential kids? Are going to feel, are families and or kids going to feel cheated somehow that they're getting something different than everybody else? I have to say, I don't believe we've experienced that. The kids have melded into our milieu just like every other child, and children discharged from a residential setting for almost an infinite number of reasons that may or may not have to do specifically with the goals that are presented when they come into us. And these kids are no different than that. So I think the rotation of kids coming in and out really hasn't been an issue like people were worried it would be.
I would echo that. That's been my experience of just what I've seen, during staffings and families' contact with the RTC, is that has been relatively seamless, that kids settle in fairly quickly. We're seeing what they usually do
Right.
fairly quickly. There's not really much of a honeymoon at all, and
Right.
that's been helpful in this overall process. So, okay. I guess perhaps what has surprised you most as you've tried to kind of incorporate this model and do this type of work? Is there anything that has surprised you the most in this type of work?
Actually, it's gone, I think, considerably, smoother than I had anticipated it would, to tell the truth, because we are shifting. This is a paradigm shift from how our world, in the residential world, often operated. And and there was anxiety, and there still is. I think people are still learning. I mean, it's not like it's a finished product, but and we've had some challenging cases, as you know, that we've had to work through some things. But by and large, it's gone, I think, really very smoothly.
Right,
Yeah,
right.
For as radical a shift as what was being proposed in this program.
And I think what I've appreciated is that the RTC has allowed, certainly our therapists to come in, but that collaborative nature of this work, that people have gotten on board about the need to kind of share information, to be working together on these cases, and that has made this process so much easier, rather than this is turf wars, things like that.
This is mine, this is yours.
Right.
Yeah.
Right.
And it's works because the two organizations, they have to be on the same page with each other, because RTCs have developed over the years boundaries around allowing outside professionals to come in, because it can complicate the treatment. It always complicates the treatment when those two parties aren't on the same page with each other. And so we've learned from experience that it doesn't really provide any benefit when there are two different sets of professionals who have different opinions and they're trying to work with a particular family at a particular time. So the key to this is being able to have both organizations on the same page with what we're doing, and the staff to get on the same page with what they're doing. And when that happens, then the work is.
And I think we have the realization, and that's why probably inherent in this model, it's the built-in communication. For instance, the staffings that occur every other week or weekly, like you said, at the CIBS level. Frequent contact, particularly between the in-home therapist and the milieu therapist. And so just those things need to happen, because the pace of change seems to be that much faster.
Right. Yeah, and it's more challenging for the residential staff because the intensity level is higher. When kids stay with us for a longer period of time, sort of that work is spread out. A month's worth of work might be spread out by 3 or 4, and it gets collapsed. In a month. So it is more intense for that period of time.
Right. Okay. Well, any other final thoughts that you would care to share about that staff should know about doing this type of work?
Well, they should know that all the skills that they have for other kids really work with the kids that are coming through this model. Residential staff and our staff, I think in particular, are really experts in helping kids move through transitions. And so, kids come in and they get acclimated, and then they go, and they have to go through that transition of now I'm leaving. And so these kids are no different than those kids. All the skills that they use in relating with kids and establishing relationships is really all the same. Their work is still, as you said earlier, it's really critical to this process and highly valued. Right.
Well, thank you so much, John, for sharing your thoughts and insights on the RTC component, particularly of the Collaborative Intensive Bridging Services model.
Great. You're welcome. Thanks.
As you have seen, Collaborative Intensive Bridging Services provides an intensive yet effective way of treating youth with behavior problems and the families they live in. This program helps to minimize the problems caused by placing a child outside the home and treats the problem behavior in the environment which it occurs. As our model continues to evolve, we look forward to continuing to provide high-quality, integrated care to the families we serve. For more information about CIBS, please contact us at contact@facts-mn.org.